All right, so we talked about mandibular anterior repositioning appliance. We talked about the concept of growing mandibles, and our understanding last week was that you can't grow mandibles, okay? This has been well documented. We're going to talk a little bit more about that today, and to see if that dogma is actually dogma, or if there is room for abilities to do things that we didn't used to be able to do using tools we didn't used to have. So again, Mara was 1994. Now, we didn't go into this in as much detail about Maras and Herbst and how they work, but I want to talk to you a little bit more about it today so that you can kind of understand what may be happening on some of these cases I'm going to show you. And the first one I'm going to show you is one that I treated. We'll skip through that. We watched it last time. The first one I'm going to show you is one I treated, and then I'm going to show you some other cases that I was treated. But these concepts of moving the mandible forward and obtaining some skeletal change is kind of what we're looking for, right? I mean, that's like the golden goose, right? So we talked about maxillary protraction with skeletal anchorage, without skeletal anchorage. Showed you, before and afters as far as like what can happen as far as moving the upper jaw. It's been well established for a long time we can influence the upper jaw, right? But the lower jaw has always been that thing, well, yeah, you can influence it, but then it's like they would have grown that way anyway. When you do the case-controlled randomized trials, there's no difference, right? It's just that you have it at a different time. You get it now versus later, which again, I think there's some good arguments for getting it now versus later, even if you would have got it later, okay? But here's a list of kind of everything we talked about last time. These are all the different fixed functional appliances, right? And there might be some new ones now, I don't really know. But these are kind of like fitting into kind of what they do, right? You have your distalizing appliances primarily. You have your class 2 appliances. You have your class 3 appliances. Those are the fixed ones. I never knew that corn had a fixed appliance, but that's kind of cool. Good to know. And I don't know, it's like a lip bumper, right? So maybe that's inspired by that. I'm not really sure. But this is what it actually looks like. And when I saw that, I was kind of curious to see like what the corn appliance was. So now you know. And then, removable appliances. The LSU activator, that's basically a fancy bionator, right? So same idea. These are some of the beginning ones, right? The very, very beginning, this is how we used to do functional appliances before we even knew what we were doing. I mean, we had 2D imaging at that time, okay? So let me show you a case, all right? So this is one of my cases. This was the initial presentation. And I think I mentioned to you guys that I don't typically do a lot of functional appliances, right? So, if I can correct it with, a motion, which is mostly a tooth mover, occlusal plane angle, or, a forceps, which is, again, more of a tooth mover, power scale, like rubber bands, like, that's typically what I'll do for certainly, half step or less. And or when the chin is not pretty recessed. But like you get a case like this, and it's like, well, what do you do? I mean, obviously, anybody who's seeing this case is going to want to get the lower jaw as far forward as possible. So, how can we do this? Are we going to get a better result using some type of functional appliance than if we don't? All right, so here's the initial pano. You can see, I mean, there's not like a ton going on dentally that I'm super concerned about. I mean, the 12-year molars seem to be coming in okay. Canines aren't impacted. But when we look at the profile view, the soft tissue profile, you can see, I mean, there's more of a steep vertical plane. And, the mandible's quite set back. You have the lower lip eversion that's oftentimes associated with that excess overjet. You also have a little bit of vertical maxillary excess. You have probably 4 millimeters incisal display at rest. And again, not that your Ceph always indicates their actual rest position, but it's a pretty good, most of the time, unless they're doing something funny with their lips, it's a pretty good measurement. Airway standpoint, again, normal for her age, not overly concerned about that, but worth looking at. And we can see here that when we're starting, the jaws the condyles are, into the fossa, maybe a little bit more to the anterior portion of the fossa, right? And so if anything, she might be postured forward a little bit, so I'm not really counting on any, like class 2, div 2 rebound growth as soon as I bracket this patient up, right? If anything, I might have more of a problem than when is indicated here. And then, of course, we're going to look at the jaw widths. Now, the upper jaw is about 47.5, lower jaw is about 47. What is ideal for jaw widths as they relate to one another? 5, yeah. Okay, 3 to 5 millimeters, right? We want the upper jaw 3 to 5 millimeters wider than the lower jaw. Makes sense when you have, 2.5, 3 millimeter overlap of the teeth on each side. The roots can be upright in the bone. The upper teeth fit on the outside of the bottom teeth. And you can see here there's slight compensations. So not a huge discrepancy. You know, skeletally, maybe a few millimeters would help, but definitely, you know, this isn't like a big jaw size discrepancy case by any means. So when you look at a case like this, I mean, what are you thinking? Like, what would you do? Like, what's going through your mind? How are you going to approach this? Like, what are you thinking about? What is your problem list? Like start dissecting this case a little bit. What are you seeing that needs to improve? Okay, and so we talked about the jaw with expansion, but what else is telling you that we might need expansion on this case? Or, put a different way, what other benefits would you expect with expansion on this case? Okay, spacing. So there's crowding, right? I mean, we see that there's crowding. Now, if you had to classify that crowding as mild, moderate, or severe, like what would you classify it as? Mild. Now, why do you say mild? Because if you looked at this and you showed this to a patient, they would probably say, oh my gosh, that's severe, right? But why do you say mild?
I mean, there's a bit of spacing for the teeth that are erupting, and there's only a bit of overlap between the anterior teeth.
Yeah, so you have spacing here, right? You have even a little bit of space here. You have probably more space than you need for the canine there, all right? So we have room. You can imagine if those teeth were in and straight, it wouldn't require a lot of room. Now, who does anybody disagree with mild? Nobody? All right, if you had to make an argument for moderate, what would you point out? What would you point out here that might indicate that maybe, yeah, she's proclined a little bit, right? A little bit of proclination in the anteriors, right? So, you know, maybe bringing those back requires a little bit more space here, okay? So, expansion, all right? So once we decide we want to do expansion, I mean, what kind of an expander are we going to do? Okay, you could do a Hyrax, you could do a bonded RPE. She's young enough, right? We know that whatever we use is going to probably be effective from an orthopedic standpoint, right? Depending on what we use and how much anchorage we have will depend on how much tooth tipping we get versus how much skeletal change we get, right? Because our expansion equation is always anchorage versus resistance. Now, we have control over the anchorage by the appliance that we select. We don't have as much control over the resistance because teeth, PDLs, in the suture, the maxillary suture, all these things vary from patient to patient. Now, we can look at the x-rays and get a good idea. We can see how thick the bone is. We can see, do they have a tori? You know, like all these things we can guess as far as what our anchorage requirements are based on how high we think our resistance is, but it's a guess, right? At some point, I think we will be able to take an image, throw it into some AI system, it'll analyze it, the density of the bone, it'll have a number of factors that it goes off of where the roots are, blah, 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 and it will tell us like, hey, you know, put bands on the 6s and 4s, put them on, you know what I mean? It'll give us a more predictable option list for expansion in order to achieve what we want to. We're not there yet, so we do our best to guess. So one option is, you know, Hyrax or bonded RPE. Any other options for expansion? And why? Or is that what everybody would do, either one of those two? That's not what we did. Okay, you could do arch wire development. And what would be the reason for doing that? Okay, so why would we thought that we needed, you know, 3 to 5 millimeters of skeletal difference. So what benefit would doing arch wires give us? Because I'm not saying don't do it. I'm saying if you do it, have a reason for doing it, right? So if our ideal, if we agree on that, and again, I'm saying you have to agree on that. You might not agree. You might say, oh no, like that's aggressive or whatever. It's going to make her cheeks. There's a number of reasons you might disagree. But if you agree that the goal is to get orthopedic change, then there needs to be a reason that you would use an appliance that you know is not going to change it. You know, the benefits of using something that's not going to change the bones orthopedically needs to outweigh that initial benefit that you thought of. So are there any benefits to doing, or what would be an acceptable benefit to doing braces alone or aligners alone versus an expander? What would be acceptable? What would be a good reason for that? Knowing that our goals are what they are. There's a huge one. Someone's got to get it. It's not a trick question. It will happen to all of you in private, probably already does, even in school. You present a plan that's ideal, and what happens? Ish. The patient may not want it, right? The patient has choice. We don't force patients to do treatment. We offer treatment, right? So if the patient says, I don't want an expander, okay, that's an acceptable reason to treat this case with braces only, if you're comfortable doing that, right? You might not be comfortable. You may be like so firm in your belief that this is what that case needs and it's going to do the patient harm to treat them with braces or aligners, in that case, you should not be the one that treats them. You can just tell them, hey, look, I understand what you want. Like, and a lot of orthodontists will do it that way. I'm sure you'll find one. It's just for me, like, I don't believe that's what's best, and so I don't think I'm going to be the best one to provide care. I mean, you have that option, right? And I would encourage you always to use that option if a patient is asking you to do something that you are not comfortable with, okay? Now, I have patients ask me all the time to do things I am comfortable with, and that's fine. You know what I mean? Like, I explain it to them. It's their choice. And so I'm not there to, like, bully them into doing what I think is best. I'm giving them my opinion. I'm explaining what the options are. If this patient told me that she didn't want an expander, I'd be like, okay, we're going to get you the best result we can without an expander. And these your bones aren't going to change. That's fine, but yeah, we're going to do our best. And I'm comfortable with that because we're not doing harm, right? I mean, we're still going to make a number of improvements, even though in my mind it's not ideal. All right, so any other guesses on, we mentioned Hyrax and bonded RP. Any other guesses on possible types of expanders that we could do that would address our goals, specifically our skeletal goals? Expander? Well, okay. Yes. Yes. But with one other thing as well. Okay. So now we think about this. So this, I need you guys to and I'm going to try to bring the pediatric dental residents along with us here because I know you guys haven't done a lot of fixed functional or functional appliances, and I'm assuming you haven't got a ton of training on it. All right, except for what we've talked about here. But you understand the concept, right? These functional appliances, they connect to the teeth, right? Typically the molars, sometimes the premolars. And so there's something that's connected to the teeth. So your anchorage is what? Like what anatomical feature is your skeletal anchorage? What is it when you're connected to the teeth like that? It's the roots, right? So your roots are the anchorage. So when you're pushing that lower jaw forward, this is a high level of force. Depending on the patient, right? Some patients are stronger than others, but you are pushing their lower jaw forward and holding it there. And the anchorage that's holding it there is the roots of the teeth, okay? So what happens when force is placed on the roots of the teeth? The teeth move, right? At least they should, unless they're ankylosed or something like that. I'll show you guys another case, not today, but later, of a case that went totally haywire due to one ankylosed tooth in an adult that I did not identify, all right? And it's crazy, but we're recovering from that now. It happens, yeah. So, but yes, if the teeth are not ankylosed, then the teeth are going to move. All right. So when you put a functional appliance in initially, where does the condyle go? Yeah, out of the fossa. You're holding it out of the fossa. How long does it stay out of the fossa? Yes, the condyle remodels. That it also remodels during normal growth. But yes, there's deposition at the condyle during normal growth, and there is some deposition at the condyle when you pull it out. And again, that's the accepted effect of functional appliances, is that you pretty much speed up that condyle remodeling and get the growth now versus what you would have got later. So when you do a traditional type of Herbst or functional appliance, that condylar remodeling, instead of getting like 100% over 10 years, you're getting like 90% here and then the other 10 later. So it kind of like you get it now and then it slows down, so it equals out in the end. But yes, the condyle is remodeling, okay? But my question is this. As the teeth move, right? The teeth are moving. We said that the teeth are moving. As the teeth are moving, what is happening to the condyle?
It's slowly going back to where it was.
Why is it slowly going back? Yeah, because that's the force that's pulling, right? I mean, it's like, why does a tooth move that way when you put a wire in? Because that's where the wire's going, right? So the forces are pulling the condyle back, and you're losing, quote-unquote, skeletal anchorage as that process happens. So the lower teeth are moving which direction? If you're bringing the lower jaw forward, what direction are the lower teeth moving? Forward, as the condyle moves back, right? Now, same thing. If this appliance is hooked to the upper teeth, what direction are the upper teeth moving? Backwards, right? And we see that, right? We make space for these five. So the lower teeth are moving forward. The upper teeth are moving backwards. And as those two things are happening, the condyle is moving back toward the fossa, okay? when you look at the research on how long this takes, it's about 2 months. Meaning that if you cone beam your patient, and again, this depends on how far you activate the Herbst, the Mara, the twin block, whatever you're using. But in general, about 2 months later, that condyle is in the fossa. Okay? So then what can you do? You can reactivate the appliance, right? So now we activate the appliance, we move it out, and then a couple months later, where's the condyle again? It's back in the fossa, okay? So when we're trying to affect skeletal change on these patients, this is problematic. Because ideally, if we look at the way we do the maxilla, we want a constant force. We want them to wear the face mask day and night as much as possible, or at least at night every single day. Like, we want to keep these forces on the bones consistent to get the best result. And our traditional functional appliances aren't able to do that because they are anchored to the teeth, which are moving, okay? So it's constant flux. Now, you can see here, where are we anchored in addition to the tooth roots? We're anchored directly to the jaw, right? So now, yes, on the lower, you will see that those lower teeth can move forward, right? But the upper teeth shouldn't move back, at least not significantly. I mean, maybe to the extent that those metal arms can bend a little bit or flex a little bit. But at a certain point, that bone anchorage is going to win as long as the anchors don't fail. All right, so that's what the top looked like. This is what the bottom looked like, okay? And my thinking was, well, at least there's half as much tooth movement, right? And we're getting more in the lower. I don't want the upper teeth to move back. Certainly not that much. There's already some space possibly to resolve the crowding. I'm doing an expander. I'm making more space. So I don't need more space to resolve my dental situation. I've got plenty of space just with the expansion to get those teeth upright. So I want to use as much skeletal anchorage as possible. So this was 7 months later. You can see that the braces are on and the MARPI has been removed. Okay? And now ortho residents, when you look at this, and if somebody showed this to you and then they moved on to the next thing and like, oh, cool, like, look at this, I'm a great orthodontist. Like, what's your, like, hey, wait a minute thing? What's going off in your mind right now? Like, hey, wait a minute. Like, what are you curious about? What do you want to know? What would you want to know? Like, if I said, hey, look at how good a result I go into class 2 to class 1. Like, well, it is 7 months. I'm not lying about that. What's that? Okay, why stability? Like, tell me more. What do you mean? Yes, that's what I would want to know. That's exactly what I would want to know. Okay, cool, you showed me this, but like that doesn't mean anything. Like they could just be moving their jaw forward. Yeah, the teeth fit better there. You have arch wires in. Every time you put arch wires in a patient, you are essentially coordinating them to a class 1 bite regardless of where their teeth are. Does that make sense? Or regardless of where their jaw joints are. You are coordinating them to fit together where their teeth should fit together because that's what the arch wires are designed to do. They're coordinated. It doesn't matter if their jaw is set back. They should be able to, unless there's a left-right asymmetry, move their jaw forward and get it to fit, right? So if you're not checking for that, that's a problem. Whenever you see presentations like that, that can be a problem. All right, so here's our initial. Here's our progress. Okay. Here's our profile view. All right. Now, did we sacrifice the nasolabial angle as you have seen on some of those other cases that we went through last time? No. In fact, what do you notice about the nasolabial angle? It's better. Why is it better? What's that? Who agrees the maxilla grew? Well, yes, she's growing. Maxilla grew. Yes, can't argue with that. Okay, but who agrees that that's the reason that we're seeing a better nasolabial angle, or the biggest reason? So if I told you not to use the word grow, but something with the maxilla, what else? How else could you describe it? Who took my MARPI course? Dang it. What happens when we expand? Down and forward, right? So part of this can be explained by the movement of the maxilla down and forward. Now, what's another big part of how this can be explained? And again, go back to what we're trying to do with this case. What's that? The mandible came forward. The soft tissue came forward. Yeah, so you have more support of the soft tissue, which is going to push the upper soft tissue forward as well, right? So all this makes sense. So now the biggest elephant in the room is, did we actually do this, or is she just posturing forward, right? Well, we can tell now because we have cone beam, and we can take one before and we can take one after, and we can put them on top of each other, and we can see exactly what happened in ways that we never used to be able to. All right, so here's our before and after. Still can't tell. Condyles aren't there. All right, here's our before and after airway. Okay, still can't tell. Condyles aren't there. Here's our before and after skeletal change. Okay, I mean, we could have probably gotten even more skeletal change, but you can see where the dentition was at that point, and also she was a little bit gummy to start. We mentioned the more we expand skeletally, like I've had to learn skeletal expansion changes faces, 100%. Okay, you have to account for that so that you don't make it worse. I probably talk more people out of skeletal expansion than I talk into it, okay? And the reason for that is that some people just want it and they don't understand what it's going to do. I'm in the process of putting together a whole collage of faces so that when people come, they can see the changes, like different age groups, different genders, like, hey, this is what you can expect with this much expansion, okay? So this is where I felt it was appropriate. I did not think we would get facial benefit changes if we expanded any more than that. So what happened? Let's look at it together. These are the 3D superimpositions, okay? So this shows us the changes that happened. Now you can see here it's superimposed on the cranial base. So as the jaws are moving, you can see that the anterior cranial base is not moving, okay? Now is this a perfect superimposition? No. I'm not a radiologist. I'm not a 3D superimposer, but it's way better than anything I used to trace by hand on a 2D Ceph, right? I mean, we're close. We are in the ballpark here. So look at, well, my first question for you is I showed you a pretty dramatic airway change, right? You guys all saw it, right? I could have left it there, and you would have thought, man, this guy can make people breathe. Now, who after seeing this is as impressed as they were when they first saw that volumetric analysis? Are you more impressed or less impressed seeing this, and why?
I'm not impressed. It gave more like increase the tongue space and everything came forward as well.
Okay.
You talking about the airway?
I'm talking about the airway specifically for a second.
So I feel like just the angle of her spine is different in the second one, so that's going to open her airway up more.
A lot, right? And I'm 100% agree with you. Like, I feel like the majority of the airway change you saw was simply a difference in head position. Look at the difference in the head position. Look at that spine, how much further back it is in the after image. Did you notice that when I showed you the before and after airway images? It wasn't like obvious, right? It didn't stand out. I didn't either. Like when I don't tell them, like my team takes these images. I don't tell them where to put the head. They try to do it the same every time, but obviously they don't. Could have been the opposite, right? And so like when I looked at those before and after images, I was like, oh, that's interesting. And I'm like, this looks like a pretty cool airway change. I look at it here, I'm like, like not so impressed, right? That could have been taken the same day, you know? So the airway changes, you know, here and there, yeah, like I would gauge that more off, you know, did her symptoms improve? Was she snoring? Is she not snoring now? Like how's her sleep? Is she, you know, all that kind of stuff. And she wasn't an airway case per se anyways. All right, so tell me what happened, or at least what looks like it happened. Let's just start with the upper jaw. Where did the upper jaw go? Okay, it came down and forward. Forward a little bit, yeah. I mean, definitely, like, would have loved to have seen it come more forward than that even. All right. Yeah, it definitely came down. And again, like, she's growing. These are taken, you know, almost a year apart. So things are going to come down. The whole face is going to come down. We know that. All right. And I can't differentiate with this superimposition what was growth and what was growth modification, right? Except for if you know what happens in normal growth, then you can deduce that anything above normal growth was, you know, induced by whatever appliance that you did. All right, so what happened to the lower jaw? Okay, it came down, and as it comes down, you can see that there's definitely rotation of the lower jaw, right? And again, I haven't showed you the body of the mandible yet, or the condyle yet, but if we, which we will, if we measured out this lower jaw and we said how long is it before versus after, looking at this superimposition, are you going to guess it's the same length, it's longer? I mean, you could guess shorter, but that wouldn't make a lot of sense, right? But like, so I mean, in your mind, like seeing this, are you thinking like this mandible is probably significantly longer? about the same? Like, what would you expect to see? Okay, maybe a little bit longer. All right, so let's take a closer look. Here's a closer look at the transverse. Okay, you can see she actually developed some sinus inflammation from start to finish. That can happen. Obviously, that's not ideal. But that is you can see the vertical and transverse changes there and the changes to the teeth. Here's our condyle before, after. You can see our condyle actually seated down back into the fossa. We mentioned before it was a little bit out, all right? So it actually seated back into the fossa, which means that something with the mandible changed maybe even more than we thought, right? So now let's take a look at, this is superimposed on the condyle itself, okay? So that will show you that we're superimposed on the condyle. So now we're going to go up to menton, and that's going to show us the changes in the length of the mandible. Look at this. Okay? So superimposed on the condylar head, this shows us the changes of the mandible. Now, is 5 millimeters forward movement of pagonion normal growth in 7 to 12 months in a teenager? No. No. Right? So now, of course, the question still remains, is this the growth that she would have had eventually, or is this something different? And I didn't have a great answer for that yet, but I'm going to show you the work of another lecturer, and he has an idea about what might be happening here, and I found it quite fascinating. All right, so this one's superimposed on the chin. You can do the same thing. So if we superimpose just on the chin, then you can go back and you can look at the condylar heads as well on either side, and you can see how they change. So superimpose on the chin, you'll see again that's going to drop back. You can see again the changes in the length of the mandible based on where you superimpose. All right, so who knows who this is? Anybody? Nobody? Like Google him or something? All right, who knows the name Hugo De Clerck? Okay, nobody. All right, this is a great place to start. So Hugo De Clerck, I've been following his work for a number of years. He is an outlier in the world of orthodontics. He treats patients differently than most do. He practices, I think, in Belgium. And he does a lot with mini plates, okay? So he published a lot of the early research. I've referenced his literature on articles that I've written as it relates to maxillary protraction. They will do mini plates for everything that they do. And there's a lot of potential with mini plates. Now, you have to get good at them. They've gotten better. A lot of them are custom in 3D now. And so you have the ability to have less failures than you ever used to. Because one of the problems with mini plates and mini screws and implants and TADs and all those things is that they fail, right? If you don't think they fail, place more of them. You'll be a believer. Yeah, like we all agree on that, okay? So he got really good at placing these mini plates, which are basically, and I'll show you what they look like, but just for description, it's a surgical procedure. They flap tissue, and a lot of times they'll place them up on the zygoma, 3 screws, and then there'll be a portion of that mini screw plate that goes into the oral cavity, so it just sort of goes through the tissue heals around it, and now you have this solid anchor connected to the bone in some area in order to try and affect some change, right? So, I mean, if you're going to zygoma, obviously you want to stay on the maxillary part of it if you want to bring the maxilla forward, right? That's where your anchorage is going to be derived from. And in the mandible, depending on what you're trying to do, a lot of times they'll place the mini plates toward the anterior mandible, right? 3 screws. And then you can use those plates for your goals. Now, one of the reasons why I have looked into doing these is because I've gotten a lot more involved with helping treat sleep apnea patients. Because here's the problem. Now, I've told you guys before, do I tell patients I'm going to cure their sleep apnea? No. But patients with sleep apnea often have large dentofacial orthopedic problems, right? And we're dentofacial orthopedists, right? So when you have a child that's been on a CPAP for 5 years and their midface looks like, it almost looks like they're Down syndrome because it's putting pressure right on their face. Now they need it to breathe. They need to breathe to grow. It's important. But at the same time, it's perpetuating the problem that they're having, pushing their upper midface back. And so with a traditional face mask, unless they can get lucky and get some sort of a nasal type of CPAP that will still allow them to use a protraction face mask, it's really, really difficult to have them wear that unless they have to, unless they just decide they're going to wear it during the day, right? And they can do that. And I would encourage that if they had no other options. But with mini plates, you could put these mini plates in and they could wear skeletal elastics to protract the maxilla full time. And they could wear those elastics at a force, at an orthopedic force level. I mean, we're talking like a pound per side or more, right? And so that allows them to wear that day and night. So you're not only reliant on the 9 or 10 hours that they sleep with our traditional protraction face mask, which we know works. You can actually get 24 hours a day skeletal anchorage. So the work that he's been doing on that is cool. That was one of the questions I asked him afterwards. Is like, hey, are you treating kids with sleep apnea? Because like your stuff would be like the best way to do it. And he's like, it's interesting because he's been doing these plates for forever, but he's only been doing it to correct, class 3s and everything like that. Like he's just now getting into the world of possibilities with what he may be able to do in treatment and help with these OSA kids. Okay? But when you review the traditional literature with traditional Herbsts, these are the things that you see. All right, these are the changes that you typically see. The gonial angle is going to increase a little bit. Your pogonion or your chin's going to come forward, 2.5 millimeters or so. And then you're going to have dental angulation changes, just like you guys said when we talked about it. The upper teeth are going to come back a little bit. The lower teeth are going to flare a little bit. And eventually, you run out of room, right? The teeth are class 1. You run out of overjet, and that's where you stop, okay? So check this out. All right, so this is what he presented on at the AAO. So he's done 93 patients. So what you're seeing here is a Herbst appliance anchored to lower mini plates, okay? So it's kind of like exactly the opposite of what I just showed you, right? So I did a Mara appliance anchored to the maxilla. He's doing a Herbst appliance anchored to the mandible. And one of the other questions I asked him, well, why don't you just anchor it to the maxilla as well? And, and basically his answer was like, well, this is a crap ton hard ortho case and we need the space and distalize and blah, 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 blah. But I'm like, but it kind of makes sense to get the jaws right and then everything else should work out, right? But anyways, like I say, this is brand new, 93 cases. So out of those 93 cases, there's 2 plates that failed. So like I say, he's gotten really good. I mean, think how impressive that is. Think of the amount of force that's on those plates. I mean, chewing, eating. I mean, that's a lot of force. I was very, very impressed with their ability. He has a surgeon. Yeah. But they do 3D guided titanium plates, and they do three pins in them, okay? So, again, what we talked about, condyle moving back with traditional anchorage, right? And so check out this superimposition, all right? This looks very similar to the case that I just showed you. If not, I mean, if anything, even better, right? Even better, okay? No, in fact, you have retroclination of the teeth. Why would you have retroclination? It's a great point you bring up. Why would you have retroclined incisors? Yeah. Well, the teeth maybe if you get there, but certainly the lip. Yeah, right? There's nothing on the teeth. So they're going to retrocline. Now, if those lower teeth retrocline, what does that allow you to do? Yes, you can advance more, right? Pretty cool idea. Very, very impressed with his work. Like I said, I'd never seen this before. This is not even published yet. You guys are like cutting edge, man. You know more than like the majority of orthodontists right now. Okay, so look at this case. I mean, it's like super class 2. It's not even just class 2. It's like super class 2. A width of 10. All right. For bonus points, can any of my pediatric residents tell me what width is? I've failed you. All right. How many ortho residents are impressed? All right. Yeah. All right. Yes, you're absolutely right. Yeah. So basically, occlusal plane, A point, B point, horizontal down to that line, and then you measure the distance, right? So 10 millimeters in this case. All right, A and B of 5, obviously that's increased. And so let's look at our pre-treatment and our post-treatment condyles. All right? Pretty interesting. Okay, let's put them on top of each other. So tongue Nguyen, I told you I'm not one of those guys that does, this is one of those guys, all right? So this, again, was more impressive to me because this is not Hugo doing his own superimpositions like I just showed you. This is Tongue doing the superimpositions for him, right? And this is like, that's what he does. CBCT, diagnosis, AI, all that stuff, okay? So let's look at our anterior cranial base registration. I showed you that before. Look at the registration on the symphysis, which is, again, what I showed you before. The crazy part about it is that I had not seen this lecture when I put together that case. I was going to show you guys that case last time, and it's just so cool that, like, we were thinking about this the same way. You know what I mean? So fossa modeling, true length. So he does a really good job of describing the 3 types of major changes that are happening. And one of them is one we have not talked about yet, and that is fossa remodeling, okay? So the actual skeletal fossa will remodel in these cases. The interesting thing is that it's not necessarily predictable which way it's going to remodel. So most of the time, it seems to remodel forward, which is good, right? When you're trying to get a lower jaw forward, if the fossa remodels and now the whole thing is a little bit more forward, even if it's only 0.8 millimeters, that's 0.8 millimeters, right? But sometimes it remodels backwards, and you actually get less of an effect. And he didn't have any good explanation on, he couldn't figure out why. Like, I don't know. Like, I mean, he's just presenting the data, right? Like, sometimes it goes this way, sometimes it goes that way. But these are what he looks like. So you have your fossa remodeling, you have your true lengthening of the mandible. So, you know, in this case, 5 millimeters. Same way we looked at it before. When you measured out lengthwise, 5 millimeters. This is over a 10-month period, okay? You know, the mandible should grow less than a millimeter in a year, right? This is over a 10-month period, 5 millimeters of true lengthening change. Now, is it growth? That's the question that we'll answer. Okay, and then the last thing you have is rotation, right? So the more the mandible rotates forward, the further pregonion is going to come forward. So in a case that's mandibular deficient, that's what we're shooting for, right? So in the case I showed you before, did we do a good job or a not so good job on this part?
I felt like it rotated backwards.
Yeah, so a not so good job, right? So our mechanics on the upper brought everything down vertically, which made the mandible rotate backwards, which is not favorable for the result we were looking for, right? So that was a downside to the way that we did it, okay? So in this case, you can see when you add those 3 things up, you're going to get the total change in pregonion. In this patient, 7.2 millimeters, which is pretty dang impressive. Have you guys ever seen a case with pregonion coming forward 7.2 millimeters? I haven't either. Okay, so this is another way to visualize it. It's a little bit easier. You can see the after tracing superimposed over the initial cone beam. And this is another, let's see, what is this one? I don't remember what that one was. Oh, okay, yes. That's the lower incisor inclination, yes. So again, you see them retrocline. Thank you for paying better attention than I am. All right, so, and then this is our change in profile. Now, interestingly, I was talking to him afterwards, and one of the things that has come up with these patients is that there's been like a handful of them that are like, the chin is too far forward. Like the patients don't like it, you know, because they've lived their whole life with a, you know what I mean? So it's like too much of a change for them. So again, like I felt his pain completely with that because you know what I mean? It's like, I'll fix things and I'm like, oh my gosh, you look so much better. But then the patient sees something they don't like. And so now it's like, I try to go overboard to it. Like I say, I talk more people out of it than into it. Like I try to explain, hey, these are the changes that you're going to see. Like, you know, some people are like, great. And some people are like, no, I don't want to see that. So, you know, something that comes up when you move chins more than you've ever been able to move them, you know, there's things that are going to be associated with that. All right, these are the airway slices. And again, he's not like the airway sleep apnea guru by any means. I mean, he kind of presented this like most people do, like didn't really show where the neck position was, just kind of mentioned it. And again, this is why so many docs don't understand this. So you guys are way ahead of the game as far as knowing what's happened. I have no idea. I didn't look at the cervical spine on his, he didn't show the cervical spine on his superimposition, so I don't know if this is impressive or not. But I mean, obviously, you would think if the lower jaw comes forward 7 millimeters, probably going to be an improvement in the airway, all right? So bone-anchored Herbst versus traditional Herbst, quite different, right? Quite different. All right, so let's look at another case. 11 years old, almost 12 years old. Another full step, class 2, widths of 6, not so bad skeletally, right? Widths is all about skeletally, as you mentioned. Okay, pre-treatment, post-treatment. So here's our registration of the anterior cranial base. You can see the difference in forward movement, more or less than the case we just showed you. Yeah, maybe a little bit less. Looks like a little bit less to me. All right, you can see the registration on the symphysis, showing the length of the condyle. And then we have our three things. So again, fossa remodeling in this case, 1.2 millimeters. Great. Like bonus, right? We'll take that all day. True lengthening of the mandible, 6.4 millimeters. But now look, like our case, we didn't do so well when it comes to the occlusal plane angle. I don't really know, and he didn't really throw out much of an explanation as to why.
Did they do expansion in this case? Because I feel like that was maybe in your case.
I agree. In my case, I feel like the expansion was probably the main contributor. And I don't know. That's a good question. He didn't mention that.
Already kind of has a vertical growth tendency, so you're just already.
It could be that. Could be that, like they're kind of high angle already, and so they have a tendency. So it could be like if they're more breaky to start, like maybe you get more better rotation, and then if they're kind of more dolicho to start, you get less rotation. Yeah, all good ideas. But that subtracted, otherwise, geez, take that out of the equation, we would have been right up there at, 7.6 again. Or have positive, it could have been even over 7, right? But, because that rotated down and back, we're down to less than 5 there for the overall change. All right, again, what's going to happen to the lower incisors? They're actually retroclining. Right? So all of that, like pushing the lower incisors out of the bone, flared teeth, like, they used to, one of my professors used to joke about it. He's like, yeah, I just put the lingual retainer on from the front. Because, like, you can see it, right? Because they're, anyway. So, yeah. All right, another case. 14 years old. These are not 10-year-olds. These are not 8-year-olds. I mean, these are like, maturing patients. These are older patients, 14 years old. Weights of 8.5. Full step class 2, A and B8. All right, pre-treatment pro. This one's more breaky. Be interesting to see. I don't remember this exact case to see what happened with the rotation, but definitely more breaky, right? Okay. Looks like we'll see. I mean, to me it looks, I don't know, looks like maybe stayed the same, maybe rotated back a little bit actually. You can see the difference in the condyles there. All right. So it looks like this one so the after is showing the condyle backwards. This was the same as in our case, right? Now I didn't measure the fossa remodeling, but this shows it really well. Do you see the actual fossa changed? Yeah, like I say, I'm not an X-ray dude, right? So I don't even know to look for that stuff. And I don't even know how. I mean, obviously they have to have the anterior cranial base superposition like dialed in, and then they have to be able to visualize that really, really clearly. I'm gonna look at this. I'm gonna see if I can go back and like actually get this same type of image, if I can like process it and get it out of there. But bad for this case, right? That's what we don't want. Again, he's more breaky. Why does it happen? I don't know. He didn't know either. Right? So fossa modeling, minus 1.2. Not so great. True lengthening of the mandible, not quite as impressive as the other cases, but still 4 millimeters. That's 3-something millimeters at least more than what you would have gotten. So total change of about 4 millimeters total, because in this case, he actually did come forward a little bit when they measured it out, 0.8 degrees. Okay? You can see before and after, and the difference in the profile. Okay, let's look at another one. 14 years old, width 7.5, full step class 2, maybe and then some on the right, A and B all the way up to 8. All right, so here's our question. This is a fun step question. So this A and B is bigger, right, than the other cases. The width is smaller than our first case. So let's just, okay, so on our first case, our width was 10, our A and B was 5, right? So this case, our width is 7.5, our A and B is 8. So our width is less and our A and B is more. Is this occlusal plane steeper, meaning more dolicho, or more breaky? And I should have just given you the numbers. But which one is it? Steeper. Now, if I didn't show you the picture, why? How can you explain that just by knowing those numbers?
Because with widths, as the occlusal plane gets steeper, widths get smaller or more negative. Because the distance between the two, you have to visualize it to see it. So like the distance between the two gets closer here.
So you're saying as the widths, as the occlusal plane gets steeper, the widths get smaller? Who agrees with that? So this, pretend this is widths. B point, A point, occlusal plane. Okay? So this, what? Okay, yeah, so this occlusal plane, now those numbers are smaller. Right? So compared to here, does everybody see that? This Well, let's just go to the extreme. This, right? Numbers are smaller. They're like 0, right? So does that make sense? So widths, the occlusal plane gets steeper, then the widths is going to get smaller, okay? So that explains the widths. So now, how do you explain the A and B? Why is that bigger? And how does that relate to vertical?
I mean, if you have a steeper like anterior plane angle, it's also gonna have the mandibles be farther back.
So now we have our A and B, right? A, B. So what if it was like this? And because we're going N is here, right? So what if I went like this and the jaw kicked all the way forward and it was like ultra brachy? Now we're to 0 again, right? So as it gets more brachy, it gets closer to 0. As it gets more dolicho, it gets bigger, right? So that will help you on your ortho boards if you understand how those numbers relate to what you're seeing facially. So we know that this patient is more dolicho just based on the numbers. Any questions on that? All right. So pre-treatment, post-treatment, obviously got her to class 1. You can see here registration on the anterior cranial base, registration on the symphysis. So more or less change than the other cases. Doesn't look like quite as much maybe to me. All right. So fossa remodeling, no change. True lengthening, 4.4 millimeters, got a little bit rotation-wise. Total pogonion change, 6.3 millimeters. You can draw that out with the after tracing superimposed over the initial cone beam, 6.3 millimeters different. All right, and you can see the profile changes there. Okay? Not as dramatic of a profile change, to me at least. All right, 15-year-old. Getting a little bit older with this. Widths of 7, A and B of 5. All right, full step class 2. You see the changes. Fossa remodeling, this one went back 0.7. True lengthening, 6.5 millimeters. Got a little bit with the forward rotation, 6.1 millimeters forward. Okay, so are we growing mandibles? Okay, we have a vote for yes. All right, is anybody going to vote something different than yes? Because we all agreed last week that we weren't growing mandibles and that we couldn't grow mandibles, right? We all agreed, right? Literature, studies, been done, can't grow them. You can just kind of get the growth a little earlier. Can't like make an overall change. So, anybody say we can't grow mandibles?
The question becomes, is it like growing or is it kind of remodeling changes?
That's the exact question. Okay? So, how do we think about this? If we are growing mandibles, how does the mandible grow? What changes would we expect to see? Where's the biggest growth site of the mandible as far as it relates to the vertical and horizontal changes of the mandible? Where's the growth spot? What's happening? Where's it growing a lot? Okay, the condyle, right? I mean, it's like a big spot for growth, right? The pluses and minuses. You remember the little bone chart, plus here, minus here, all that. There's a lot going on at the condyle, right? And that's what we've always tried to do. We pull the condyle out of the fossa, and we induce those changes. The condyle grows, okay? So, if the condyle grows, how do we know that if all we have to look at is the before mandible and the after mandible, as we've been looking at? So if it's the condyle that's growing, how would we tell the difference looking at the before and after jawbone, right? Because we have that on the image. How do we know that it was the condyle that was doing it? What would be different between that before and after if it was the condyle that was growing? What other landmarks on the mandible are there that maybe we could compare it to that would indicate that, oh yeah, there's kind of like more going on here at the condyle than there is other parts of the mandible? Yeah, tell me about the coronary process. What about the coronary process?
The distance between the condyle and coronary process will indicate that condyle grew.
That's a thought, right? So think about that. You've got your condyle, you've got your coronary process. You have that before. Now, if we were having a lot of mandibular growth at the condyle, what would you expect to see happen between the condyle and the coronoid process? It would increase, right? You would see the distance from the, both horizontally and probably vertically, right? You would see that change. You would see the coronoid process get further away from the condyle as the condyle is growing, and you would see it get further down, right? So now, what if I told you, which is what he told me, that when they looked at that and they saw the differences between the condyle and the coronoid process, they were pretty much the same, just on par with normal growth. Well, what would that tell you? Back to what you said, right? There's some other thing happening within the mandible that's resulting in the shape of the bone being different that's not quote-unquote growth. All right, so this was his hypothesis. And again, this is unproven, right? This is the first time anybody's talking about this. But what do you have attached to the coronoid process? Temporalis. So when we're talking about changing bones, what is the formula of how much the bone is going to change? And hint, it's the same formula pretty much as anything that we change. It's anchorage versus resistance, right? So if we are stretching this condyle and making it longer, then we're doing that with some forms of anchorage. Now, we know we have anchorage down in the anterior mandible with the way that he designed his Herbsts, right? Because we're pulling everything forward, and this is the part that's pulling back. So if you think of the bone itself, this part of the anchorage is anchored by a bone plate. And if that bone plate doesn't fail, that anchorage is pretty absolute, okay? Because implants don't move in bone unless they fail. So we've got perfect anchorage here. Now, what's our anchorage back here? A big part of our anchorage back here is the temporalis muscle, right? How strong of a muscle is the temporalis? It's a pretty big one, right? We chew with it, we do everything with it, and there's other stuff too, right? The condyle's attached to the disc, that ligaments. I mean, there's a lot of soft tissues that are kind of pulling that part of the mandible back, so to speak, right? So what they're proposing is that it's this stretching force of the mandible that's resulting in bodily changes near the ramus, which is what one of you said earlier, right? So it's basically, are we growing the mandible? No. But what they're proposing is that we're stretching the mandible. And, I mean, it's semantics at that point, right? Because at the end of the day, if we're doing something that gets us a bigger mandible, like, that's what we were going for anyway. So, fascinating where this will go. As soon as this gets published, I'm really, really interested to see, like, all those orthodontists. Because there's orthodontists who make a career out of defending the way that they practice for 40 years. Like, they retire and they don't have much else to do. And so, like, anytime anything new comes out, they just, like, attack it and, like, oh, this can't be right. And, like, basically they're preserving their self-identity in the way that they did things for 40 years by just attacking everything new. And, it's interesting. And I appreciate them because they're really good at pointing out flaws in things. But I just, on the other side of it, I'm like, well, I'm glad you're not practicing anymore because you're pretty close-minded when it comes to, new things that are happening. So his takeaways were this, retroclination of lower incisors is going to happen. Retroclination of the upper incisors is going to happen, of course, because he was anchored to just the teeth on the top. A significant amount of true mandibular length, not calling it growth, but true mandibular length increase. And a small amount of relocation of the glenoid fossa in an unpredictable direction. And the chin advancement, depending on the true mandibular rotation, obviously that's going to have an effect on how much chin advancement you get. Expansion of the upper arch. So his kind of conclusions about how to manage these cases is that because we're getting so much more forward movement of the jaw itself, then we're going to need to expand even more than we otherwise would have because a broader portion of the mandible is moving forward in ways that it didn't used to. So if you miss that and you kind of plan your expansion based on the old model, then you end up maxillary transverse deficient, okay? And very good stability depending on the bones, all right? Now, is stability for sure yet? No, because these cases are just now in treatment finishing up. Like I say, these are the first of them. So a year from now, 2 years from now, 3 years from now, 10 years from now, we will know, like, is this stable? Now, there's no reasons that I can think of that this would not be pretty stable, right? I mean, going back to, think about it. Like, you guys, we correct unilateral posterior cross bites. Why? What's one of the biggest reasons we do that? All right, okay, put teeth aside. Bones. What's one of the biggest reasons we correct unilateral posterior crossbites? Skeletal what? What happens to the skeletal? Yeah, asymmetry, right? One side of the jaw grows bigger. Now, when you correct it, does it just go back? Not if it was this true skeletal change, right? So there's no reason to think that this won't be stable because we know it's true skeletal change, right? So it would be very surprising and also very new if that were different. So my guess is that this is going to be around and it's going to stay. Okay. All right. Any questions about this before we move on to a different topic? Slightly different topic. Okay. All right. So let's look at this case. All right. I'm only showing you a couple photos here, but you can see here. What do you? So before and progress here. All right, so just from what you can see, I know you can't see a lot. What do you notice diagnosis-wise from what you can see on those top images? Posterior crossbite, which may indicate what? May indicate a skeletal discrepancy, okay? What else do you see? An open bite, okay? So when you have a posterior crossbite and an open bite, is that like, oh, those things pair really well together? Or is that like, oh, crap, this is going to be a really hard case? Yeah, train wreck, right? Because like as we expand, what happens? To the vertical. As we expand, yeah, it increases. Whether you do traditional high racks or whether you do skeletal high racks, the vertical increases, which makes it more difficult to manage your vertical discrepancy, right? And so like that's like a harder thing. Now, she also has what? And now let's talk about the teeth. What's your diagnosis of these teeth? Arch specific. Like you look at the arch, the teeth in the arch, what do you have? Crowding. All right, very good. We have crowding, right? So when we have crowding, how does that relate to our vertical correction? Yeah, it's harder, right? Because what happens when you resolve the crowding? Yeah, the teeth procline. And the more the teeth procline, what happens to the vertical, the open bite? All right? So I should have probably just showed you this one first. But like on a scale of 1 to 10, I mean, this patient walks into your office, like what's your like, you know, like 1 being like, oh my gosh, like why can't everybody just send me this case? And 10 being like, oh man, I know an orthodontist down the street that I think could, like where do you put this case? It's pretty hard, right? This is not an easy case, all right? So now this is our progress photos here. So what are you thinking about the result? Let me show you another one. Obviously not done yet, but what are you thinking about how this case was treated? Or is being treated? I mean, pick it apart. What's good, what's bad? I mean, like, let me just ask you this. If this were your patient, and this was your progress photo, would you be happy or would you be sad? Yeah, and you're not done yet, right? I mean, like, can you imagine, like, if this patient walked into your office, where would you put that patient on a scale? Yeah, 1. Be like, yeah, send me more of those, right? Okay, this case was treated by a GP. Marpy aligners. Okay? That's why I don't get on the you can do or you cannot do, right? Legally, they can treat cases like this. And if they're treating them like this, I'm not throwing stones at them. They've obviously gotten the education that they need, right? Now, again, a lot of practitioners do things that they shouldn't do. But guess what? Every specialty does that. You've got surgeons that do that. You have orthodontists that do that. You have pediatric dentists. Like, everybody does that. There's people in every profession that do things that they shouldn't do. You can do what you want. If you're going to do it well. All right? Awesome. That's it. It's 8:09. We could go into something else, or we can just have a chill chat, get ready for clinic session. What do you guys want to do? I feel like we've covered a lot. Crazy stuff, though, right? Yeah.
Have they tried doing that with just regular tabs? It's just too much force, I'm sure.
So here's the thing, and this is exactly what I was thinking. As soon as I saw this, I'm like, great, bone anchors is fine, but like how much easier would it be just to throw like a buccal shelf tab in, anchor it to the tooth itself, right? So it's still tooth-borne appliance, but then you have that tab because indirect anchorage tabs last a lot better, and it only has to last so that it doesn't fail, right? So you only need it to hang on. So if you have a 10 or 12 millimeter mandibular buccal shelf tab or external oblique ridge tab, and you anchor that to your Mara, to your Herbst. Now, one of the big differences is that you have significantly changed where your anchorage point is, right? So now your anchorage point, instead of being from the anterior mandible to the coronoid process / condyle, so basically your forces were here and here, which kind of makes sense if you're trying to stretch the mandible. You've now changed your forces to be here and here, which I'm not saying can't work or won't work, but it's a different force. Like, do you get more vertical change instead of more horizontal change? Like, I don't know. But you would think that it would still be better than having the teeth move, right? I don't know. So maybe you try it that way on a really brachyfacial patient first and just see. But that was my thinking, because like, this is not going to become mainstream, almost surely, right? Because guess what? Like, yeah, it's hard. And you have to have a surgeon that's on board, and you're sending them for surgery possibly multiple times. Well, why not just do surgery? You know what I mean? Like later on, right? Oh, surgery, moved it. Like that's been around forever. So in my opinion, this will not become mainstream. But if we could harness or refine a protocol where we could utilize TAD, something that orthodontists were comfortable placing, then this could totally become mainstream. Totally. Or at least mostly as mainstream as TADs are. We'll put it that way, right? Still, most orthodontists don't do TADs, which kind of boggles my mind a little bit when you think of the possibilities that you can treat with TADs that you can't treat without TADs. It boggles my mind that so many orthodontists don't do it, have no interest in doing it. Like, and it's just a difference in personalities and what you enjoy in life, right? I mean, at the end of the day, it's a job, right? We go to work to make money. That's what we do, right? So I mean, like, if you can make money and you don't have to do other things, if you don't want to do it, you don't have to, right? I mean, and a lot of practitioners, they don't get so excited about stuff like this, right? So that's okay. But if we want to take it to a bigger level and be able to help more patients instead of just 93 patients in Belgium, we've got to figure out a way to be able to do it. So on the maxilla, pretty simple. Marpy's really, really easy. Skeletal anchorage in the palate is very, very good. And at least up to this point, we have not seen or demonstrated a restriction of the growth of the maxilla, although it's something worth considering. And maybe, now that I'm thinking about it, when we talk about that vertical change, in that case that I showed you, there was definitely, like, the maxilla came down, but didn't come as forward. You guys saw that, right? And it's possible that that skeletal anchorage anchored to the, it's possible that maybe we did restrict the forward growth of the maxilla to some extent. I mean, that would kind of make sense, right? We've never, besides headgear, we've never like really tried to do that. And headgear anchored to the teeth doesn't really do it significantly, right? I mean, the max is the same. So if we start doing TAD anchored mandibular protrusion and we do it on the upper as well, like that may be an argument to do it more the way he's talking about, where we're only on the lower, especially if that effect is significant. Now, again, overall, her profile improved, her soft tissue improved. Like, I'm not upset about it. I'm not like, beating myself up over it, but it's definitely worth paying attention to, right?
You can do like true skeletal to skeletal, where you have like maxillary bone plate as well with lower plate, and you have like a piston just there. Like,
yeah.
on the teeth at all.
Yeah, can it be done? Yeah, and that again, that was one of the, that was like pretty much the biggest question I asked him afterwards. Like, why not anchor to something on the maxilla? For that matter, if you're going to be putting them on, like, why not anchor to like the zygoma? But here's the thing, like I say, there's always an opposite force, right? And bones in a growing patient, I don't care which bone you're hooked to, like, it's going to have some effect. So you just want to do it to the one that has the least negative effects and ideally positive effects, right? If you can hook it up to something that is just positive, 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 that's great. But if there is going to be a negative effect, you just want that to be the least negative effect possible. So yeah, could you put it in zygoma? You could. I mean, that's a pretty sturdy bone. So maybe the changes at that area would be less, if they're going in for surgery anyway. Or maybe we find out that, yes, the maxilla comes back a little bit, but maybe it comes forward, later on. Maybe it catches up, kind of like, I don't know. Like, there's a lot of things that could happen. We don't know because we haven't done it and we haven't looked at the cone beams a year later, 3 years, we don't know. But all those things are what we have to think about. I mean, like, personally, like, I like, especially if I had, a lot of these class 2 patients are a little bit maxillary protrusive anyways. You know what I mean? Their SNA is a little bit increased. So in my mind, I'm thinking, okay, well, let's get a patient whose SNA is increased. Let's put a Marpy on the top because, if we're using bone anchorage on the bottom, we would expect that lower jaw to come forward more. Let's get it broadened, or at least have the ability to keep turning and broadening as we're doing this. And then let's anchor to some type of a TAD on the bottom. Now, mechanically, it makes sense to have that TAD at or distal to whatever you're connected to, right? So in a case like this, since I'm not planning on doing mini plates, I would want to, if I'm doing a Mara, for instance, I'd want the TAD kind of behind the Mara, right? Because then I can just tie directly to the tooth, and that's really, really easy. If I put the TAD more anterior, well, now I've got to have mechanics that transmit that force back. So I got to bend a wire or something that's connected to the TAD, which then comes up and then connects back to that tooth to hold it. Now, is that a better anchorage point? I don't know. The bone back here is much more dense, and TADs in this area tend to fail less. They're harder to place, but they tend to fail less. So, I mean, my thinking would be like, try it at the external oblique ridge, like, buccal shelf TAD, and see what happens. And if what happens is good, then great. You use that point as your anchorage. Or if you're seeing like, oh, dang, he was getting 5, 4, 6, and I'm getting like 3, and more vertical changes, more downward backward rotation. Okay, well, maybe that's not the best way to do it. But that would be a simple way to do it, right? That would be a way that orthodontists could do it in their office if they wanted to. So, yeah, super exciting.